Morning, everyone. We are Group 4, and we are going to present our case study entitled Placenta Previa.
To start for the definition, placenta previa is a condition that occurs during pregnancy when the placenta is positioned in the lower part of the uterus, partially or completely blocking the cervix. So, placenta previa is a pregnancy complications in which the placenta implants low in the uterus, and this covering can cause severe bleeding or after labor. The placenta is the organ that develops during pregnancy and connects the fetus to the mother's uterine wall. It provides nutrients and oxygen to the fetus and removes waste products. In early pregnancy, the placenta is low in the uterus. However, as the pregnancy progresses and the uterus grows, the placenta moves up the uterus, and by the third trimester, the placenta should be at the top or side of the uterus. The placenta develops inside the woman's uterus during pregnancy and provides food and oxygen to the developing baby. However, in placenta previa, the placenta is in the lower part of the uterus, which can cause bleeding and other complications. Next is placenta previa can be classified into three. The marginal placenta previa. The placenta is located near the edge of the cervix but not covering it. Next is the partial placenta previa. The placenta partially covers the cervix but not completely. Last is the complete placenta previa. The placenta completely covers the cervix, blocking the baby's passage through the birth canal or the cervix.
So, good day, everyone. I'll be the one who discuss the signs and symptoms of placenta previa. So, as you can see that there are 4 signs of symptoms of placenta previa, but the main symptoms of placenta previa is vaginal bleeding. So, the bleeding is usually abrupt, painless, bright red. So, abrupt is sudden or unexpected bleeding. Painless is not suffering physical pain. Bright red is the color of bleeding. So, vaginal bleeding is most likely to occur in the 3rd trimester. 3rd trimester means it's from week 27 to the end of pregnancy. So, the second symptoms is the PHR, fetal heart rate. So, the heart rate of fetal is stable or normal unless the maternal shock is present. So, maternal shock is the result of inadequate supply of oxygenated blood to the tissue. It can be the result of number of different medical conditions. So the third one is the uterus. So the uterus is soft and non-tender. So non-tender side of the body parts of lesions that do not trigger discomfort upon palpations. So the last one is the abnormal placentations. So this is the position of placenta, but there are types of placenta previa which are marginal, partial, and total. So makita ni siya na symptoms during ultrasound. So the diagnosis of placenta is usually made through routine ultrasound examination. If placenta previa is suspected, a follow-up ultrasound may be recommended to confirm the diagnosis. So the risk factors for placenta previa include a history of advanced maternal age is greater than 35 years old, increased parity is the number of times that she have given birth, history of cesarean section, multiple gestation. Multiple gestation is a pregnancy with more than one baby at the time. For example, twins, triplets, and quadruplets. Smoking and use of cocaine. So proceed to anatomy and physiology of female reproductive system that will be discussed by Claire, Angel, Jacobe, and Catan.
So this is the anatomy and physiology of the female reproductive system. So in female reproductive organs, it includes several key structures such as the ovary, the vagina, the cervix, the uterus, and the fallopian tubes. So next, please. So the female reproductive system consists of ovaries. So in ovaries, females have 2 ovaries. This is a small organ that is suspended in the pelvic cavity, and it either both sides of the uterus that is responsible for producing hormones such as estrogen and progesterone. So these hormones play an important role in female traits and such as breast development, body shape, and body hair. They are also involved in the menstrual cycle, fertility, and pregnancy. So during menstrual cycle, it is where the uterine lining is where the blood and tissue came from during menstruation. And in fertility, it is where a fertilized egg implants during conception and where the baby grows. And last is the pregnancy, where the uterus stretches to grow the baby during pregnancy.
So the next one is the uterine tubes. Excuse me. The part of the reproductive organ that is the uterine tube, or also known as the fallopian tube, is or oviduct that is associated with the ovary. The uterine tubes extends on the ovaries to the uterus. So we have this oocyte, a cell in the ovary which may undergo meiotic division from ovum. So this egg travels into the fimbria structure, and then after it travels to the fimbria, it is nearly surrounds in the surface of the ovary. The fertilization, or the process in which the sperm and the egg cell unite in one of the fallopian tubes. So this occurs in part of the uterine, in which called the ampulla. And then the oocyte travels to the uterus, where it embeds to the uterine, and then this process is called the implantation.
So next is the uterus. So uterus is a big as a medium-sized sphere and is oriented in the pelvic cavity with a larger rounded part directed superiorly. It is where a fertilized egg implants during pregnancy and where the baby develops until birth and is responsible for the menstrual cycle. So anatomically, the uterus is located in the female pelvis, immediately posterior to the bladder and anterior to the rectum. So the female uterus subdivides into three main segments, from superior to inferior. First is the fundus. It is the wider or the upper part of the uterus and is a broad curved area in which fallopian tubes connect to the uterus. Next is the body. So the body is the main part of a uterus and it starts directly below the level of fallopian tubes and continues downwards. And last is the cervix. Cervix is which is the lower parts of the uterus, which extends downwards from the isthmus and opens in the vagina. And this is where the placenta blocks all or part of your baby's exit from the vagina when placenta previa occurs.
So we have the uterine walls, which is composed of three layers. The uterine walls is where it is located internally in the uterine cavity, or the space that is located into the uterus. So we have these three layers, as what I have mentioned earlier, which is the perimetrium, the myometrium, and the endometrium. If you say perimetrium, or called as the serous layer, it is the layer that is formed from visceral peritoneum, in which the outer serous layer that secretes a lubricating fluid that helps to reduce friction. Kibali, kung imong ilantaw i-based nimo sa image ng female reproductive system, ang perimetrium is the outermost layer ng female reproductive system, while the myometrium is in the middle layer that is also called as muscle layer of the fundus. It expands during pregnancy and also holds the growing of the baby, and it contracts during labor to push out the baby. And then the last one is the endometrium, or the innermost layer of the uterus, or the uterine lining, in which it consists of simple epithelial cells that underlies in the connective tissue layer.
So next is the vagina. So the vagina is the female organ of copulation that joins the cervix to the outside of the body. So as we all know that the vagina is a muscular canal that extends from the vulva to the neck of the uterus, which is the cervix. And it is where a baby descends during childbirth.
The next one is the external genitalia, which is the accessory part of the female reproductive system. External genitalia is a female genitalia that are as what I have mentioned, the accessory structure, and they are also referred to as the vulva or pudendum that consists of the vestibule, including labia minora, mons pubis, labia majora, and then clitoris, and then the glands with the vestibule. Next, please. So the next anatomy of the placenta, it is referred to as afterbirth. This is a disc tissue that connects to a mother's uterus to the umbilical cord and placenta that is responsible for delivering oxygen and nutrients. So, but not just that, the placenta is also responsible for respiratory function, excretion, or serves as a kidney function of the baby, and then provides immunity in which to be able to create antibodies that protects the baby from any viruses or pathogens. So we have these two types of surfaces in the placenta, which is also called as fetal surfaces and the maternal surfaces. If you say fetal surfaces, this is the shiny part of the placenta, in which it has an amniotic membrane, which is it secretes amniotic fluid, a fluid that is breathed in and out by the fetus and serves as a form of protection and cushion. Also, it helps to maintain constant pressures and temperatures, allows space for fetal growth, and protects against infection.
So in maternal surface, so it is composed of decidua that is commonly known as the endometrial lining of the uterus, or the lining that you shed during menstrual period. And this portion gives the structure a dark red and blood-like appearance.
Next, please. So the next one is the structure of the placenta. So we have this, as you can see, there is the fetal side and the maternal side. Kung imong ilantaw sa base sa womb ng mother, ang maternal side is amo diri ang side sa uterine wall, and then ang fetal side is dito sa umbilical cord na going up to the baby. And then these are the parts of the placenta, as what I have mentioned: the maternal vein, maternal spinal artery, basal plate, myometrium, maternal decidua, chronic plate, umbilical cord, and then the umbilical artery, umbilical vein, and intervillous space, and chronic villus. So if we say the fetal vein, it is a vein that is deoxygenated blood, but a single umbilical veins carries oxygenated and nutrient-rich blood from the placenta and delivers it to the fetal heart, which pumps it around the body of the fetus. The second one is a fetal artery. So these arteries usually carry oxygenated blood, but the two umbilical arteries collect this deoxygenated blood from the body of the fetus and carry it to the placenta. The next one is the fetal vein. This is the mother's veins collect deoxygenated blood from the placenta. As the blood passes through her liver and kidneys, it dissolves and waste products removed, including those collected from the placenta by her endometrial veins. Next, please. And then the maternal artery is the mother's arteries carry oxygenated blood around her body, pumped by her heart, and then her endometrial arteries bring blood to her uterus and into the placenta, delivering oxygen from the mother's lungs and nutrients from her digestive system.
So the next one is the umbilical cord. So umbilical cord forms around the 5th week of pregnancy and can grow up to 20 inches long and full term. So umbilical cord, it is where the baby connects to the mother's placenta. So during fetal development in the womb, it serves as the lifeline to the baby, supplying nutrients. Next is the intervillous space, or the lacunae. So the intervillous space of the placenta is a part of the fetal to maternal interface where maternal blood enters and carries oxygen and nutritional materials that are necessary for fetal growth and development. So this space of the placenta contains maternal blood, so which is derived from the lacunae that develop into the cincture tuberculus during the second week of development. So the last is the chorionic vellus. So chorionic villi are microscopic or finger-like projections that contain capillaries for blood to flow through. So in chorionic vellus, when we say chorionic vellus, it is a membrane full of blood vessels that surrounds the embryo to help transfer nutrients and oxygen from the mother's bloodstream to the future baby throughout pregnancy. Next, please.
So to understand fully the function of the placenta and how it is important during pregnancy, so this is a fetal circulation. A fetal circulation is a process in which it allows the fetus to receive oxygenated blood and nutrients from the placenta. So today, I am going to discuss the process on how the mother transmit oxygen and nutrients to the fetus. So first, the blood reach the nutrients and oxygen supplied into the placenta. So from the placenta up to the umbilical vein, so the flows through the umbilical vein to the ductus venomus. So the residua mo travel, and then blood flows from the ductus venosus into the inferior vena cava. And then after that, the blood flows up to the right atrium, and then this blood mixes with blood returning to the heart and from the body via superior vena cava, so the residua. And then once the right atrium, some of the blood flows from the right ventricle, and then the blood flows through the foramen ovale, through the left atrium, and into the left ventricle. And it is where it is pumped in and out into the aorta of the body of the fetus. So this is the process in which cyclical lang siya. And then we have to take note that the maternal blood and the fetal blood don't actually mix because of the placental barrier. And then so nga na si placenta ka-important because like siya ang ang part ng sa pagbuntis ng mother na mag-allow na mag-transmit ng oxygen and nutrients, and also even protecting the baby.
Next, please. So this is the normal placenta. So the placenta consists of umbilical cord, fetus, uterus, and the cervix. So the usual term placenta is about 22 centimeter in diameter and 2.0 to 2.5 centimeter thick. So it generally weighs approximately 470 grams to 500 grams or 1 pound. So in most pregnancies, the placenta is located at the top or side of the uterus. Next, please. So these are the 4 types of degrees of placenta previa. Number 1 is the low-lying placenta. So the placenta is in the lower segment of the uterus but does not reach the opening of the cervix. So as we can see in the picture, it partially implanted in the lower uterine segment with the inferior placental edge located at 1 to 20 millimeter from the internal cervical os. So the second is the marginal placenta previa. So this type of placenta is located near the cervix but does not cover the opening. So it is where the placenta is at the margin of the internal os. So the third is the partial placenta previa. So in partial placenta previa, it covers some part of the cervix but no cover fully when dilated. And the last is the complete or total placenta previa. This type of placenta is also known as the type 4 placenta previa, and the placenta is covered all over the cervix, which is the opening part of the birth canal.
Good day, everyone. So this is Coleen Caluña speaking, and I'm going to discuss with you the pathophysiology of our case, Placenta Previa. So as we all know, Placenta Previa is the presence of the placental tissue that extends over the internal cervical os. The pathogenesis of this is unknown, but there are risk factors such as the precipitating factors, maternal smoking, cocaine use, and poor vascularity, as what can you see in the illustration. And there are also predisposing factors such as history of suction curettage, advanced maternal age, multiple pregnancies, and of course the previous uterine surgery or cesarean sections. So there are types of placenta previa, but all of these are diagnosed early in pregnancy on routine abdominal ultrasound at 18 to 20 weeks of gestation. So during the third trimester, there will be a stretching of the lower segment of the uterus that will occur. And when this happens, there can be two alternating scenarios that can be possible that the mother will acquire. So as you can see in the left side, the green boxes, this is the one scenario that can occur to the mother. So the stretching elongates the space between the cervix and the placenta. In this case, as the uterus grows, the distance between the cervix and the placenta may increase, in which the direction of the growth of the placenta may be higher in the uterus, and the edges of the placental tissue near the cervix may shrink. So it will absolutely relocate the stationary lower edge of the placenta away from the cervic os, and the reason why it can resolve on its own. But in order to do so, in order to clarify, we should have to reassure the patient by mag-ultrasound the subsidia utero, and we have to reassure that the placenta is greater than 2 cm away from the cervical os para makadeliver na ang mother vaginally. Yes. On the other side, or in our case, the placenta previa, kanang sa center ng mga boxes, color white, the stretching fails to move away from the placenta. Mao ang previa persist as uterus changes in preparation for the labor. So dira na mahitabo ang mga thinning of the lower segment of the uterus. Mao na ang mga clients manifestation kanang mga yellow colored na box, as you can see. Thinning of the lower segment of the uterus, uterine contractions, and cervix become thinner or effaced or dilates kanang ma-open siya. It will lead to shearing forces of the placental attachment site, which will manifest the client to have 90% of painless bright red vaginal bleeding. On the other side, it will lead to bleeding. Diba, nag-bleed naman siya. So, it can limit the oxygen delivery to the placenta, which will injure the placental tissue. Malid po siya sa tissue injury, which will activate the intracellular G protein na itong signaling pathways, and it will also release stored intracellular calcium, or katong ginatawag nila nga myometrial contraction, that can also lead to uterine contraction and bleeding 10%. So these client manifestations can put our client at a very high risk of clinically significant hemorrhage. Now, in this part, as you can see in the box, so if the patient is treated, or there will be a management of the hemorrhage, it will lead to complete recovery. On the other side, if the patient is left untreated, there will be major hemorrhage, and then it will eventually lead to shock from blood loss, and then multiple organs will fail, and unfortunately, it may cause to death. So, I think that would be all. Thank you. Kindly base the legends na lang sa mga box nyo nakita sa taas. Thank you.
So I'll be tackled about medical management. So first is IVF therapy. IVF therapy is used to maintain the fluid balance in the body and manage complications such as bleeding or shock. And IV fluids may be given to help stabilize the mother's blood pressure and maintain adequate blood flow to the placenta and fetus. The next one is vaginal birth delivery is always safest for an infant, but may also be birthed through CS using classical approach if bleeding is profuse. During the labor, which can be life-threatening for the baby and the mother. If these situations, a classical approach may be used where a vertical incision is made in the uterus to quickly deliver the baby and to stop the bleeding. Patients remains in the hospital for bed rest, post observation for 48 hours to closely monitor her conditions and to prevent potential complications. Betamethasone drug is hastened fetal lung maturity may be prescribed if fetus is less than 34 weeks maturity. Recommending is given to women 12 to 24 hours before birth. So this type of drug is a steroid medication and helps them to expand and functions properly and help prevent respiratory distress syndrome or RDS in the newborn. When we say the RDS is breathing difficulties to the immature lungs in the newborns. Therapeutic management. The bleeding of placenta previa, like that ectopic pregnancy, create an emergency as the open vessels of uterine decidua or maternal blood place the mother at rest for hemorrhage because the placenta is loosened. The fetal oxygen and nutrient supply may also be compromised, placing the fetus at rest as well. So this is concerned that preterm birth can lead to complications for the baby such as RDS or respiratory distress syndrome, infection, and brain damage. It is essential to manage the placenta previa carefully and promptly to minimize the risk to both and the baby. The next one, immediate care measures. To ensure an adequate blood supply to a woman and fetus, place the woman immediately on bed rest inside laying position. Be certain to assess the following: duration of the pregnancy, time the bleeding began, women's estimation of the amount of blood as her to estimate in terms of cups or tablespoon. A cup is 240 ml, a tablespoon is 15 ml. Whether there was accompanying pain, color of blood, red blood indicates bleeding is fresh or is continuing. What she has done. If anything for the bleeding, if she inserted a tampon to halt the bleeding, there may be hidden bleeding. The next is whether there were prior episodes of bleeding during the pregnancy. The last, whether she had prior cervical surgery for premature cervical dilation. Thank you.
I'll be the one who tackle the nursing consideration. First, inspect the perineum for bleeding and estimate the percent rate of blood loss. The bleeding with placenta previa is usually abrupt, painless, bright red, and sudden. The bleeding may be provoked by intercourse, vaginal examination, or labor, and at times there may be no identifiable cause. Weighing perineal pads before and after use and evaluating the differences by subtraction is a good method to determine vaginal blood loss. Next, an up or canor birth test can be used to detect whether the blood originates from fetus or the pregnant patient. Next, obtain the baseline vital signs to determine whether symptoms of hypovolemic shock are present. Then continue to assess blood every 5 to 15 minutes or continuously with an electronic cuff. Never attempt a pelvic or rectal examination is because an agitation of cervix when there is a placenta previa might tear the placenta further and initiate massive hemorrhage, possible fatal to both pregnant and fetus. Then Then attach external monitoring equipment to record fetal sounds and uterine contraction. However, avoid the use of internal monitor for either fetal or uterine assessment to prevent hemorrhage. Because internal monitor for either fetal or uterine assessment is contraindicated. Fetal hypoxia may be occur of a large disruption of the placental surface, reduces the transfer of oxygen and nutrients. Then next, hemoglobin, hematocrit, pathrombin time, partial thromboplastin time, fibrinogen platelet, course type of first match, and antibody screen will be assessed to establish baseline or to detect a possible clotting disorder and ready blood for replacement if it is necessary. Then, monitor urine output frequently, as often as every hour, as an indicator that the blood volume is remaining adequate to perfuse the kidneys. And administer IV fluid as prescribed, preferably with large gauge catheter to allow for blood replacement through the same line. Attach ringer lactate or normal saline and rapid rate if a shock is present. Reduce the infusion rate to 3 minutes when the pulse slowed down to less than 100 beats in minute and systolic BP increased to 100 Hg.
So here are the nursing interventions. Ensure CBR. This is to avoid premature delivery and place the woman immediately in side-lying lateral Trendelenburg position. This is to prevent maternal shock and fetal hypoxia. Assess duration of pregnancy and time of bleeding began. Instruct woman to estimate amount and color of blood. Assess HGB, HCT, PT, PTT, fibrinogen, platelet, type, and cross-match screening to detect possible clotting disorder. Ready blood for replacement if necessary. Maintain sterile conditions for any invasive procedures, including vaginal exam. Rectal or vaginal exam should not be performed, and make provision for emergency CS birth. Continue to monitor maternal or fetal vital signs, INO, and central venous pressure. Teach the patient to immediately identify and report signs of bleeding and cramping. Anticipate need for electronic fetal monitoring and assist with application as needed. Have oxygen readily available for use for when fetal distress occur. If patient is Rh negative, or administer immune globin within 72 hours of post-op. And lastly is explain to postpartum care to the patient and family to gain cooperation.
Today, my topic today is prevalence. Placenta previa is a condition in which the placenta partially or completely covers the cervix, which can cause bleeding during the pregnancy and delivery. The prevalence of placenta previa varies depending on several factors of cesarean section and another medical condition. So according to study published in American Journal of Obstetrics and Gynecology in 2020, the overall prevalence of placenta previa in United States was 0.53% of all deliveries. The study found the prevalence of placenta previa increased with maternal age reaching 2.32% in woman age 40 years or older. Other factors that increase the risk of placenta previa includes a history, cesarean section, multiple pregnancy, and certain medical condition such as uterine abnormalities and smoking during the pregnancy. In a woman with a history of cesarean section, the prevalence of placenta previa can be as high as 3 to 4%.
So, good morning. Good morning. I will be the one to discuss the prognosis. So, neonatal prognosis. There is a 3, 4, or 4-fold increased neonatal mortality and morbidity rate with placenta previa, primarily from preterm delivery. The neonate is at increased risk for preterm birth and lower birth weight or lower Apgar score, and increased risk for respiratory distress syndrome. Then the maternal prognosis. So about 90% of placenta previa cases through delivery. Jing et al. Found out that women with anterior placenta has a poorer prognostic factors are more likely to have massive blood loss and higher hysteromic rates to compare to any locations. So when we say anterior placenta, it is attached to the front wall of uterus between baby and tummy. Prognosis of placenta previa depends on several factors, including the severity of condition and gestational age of the fetus. This outcome is secondary for the placenta attaching to the prior uterine incision causing PAS. So when we see PAS is placenta accreta spectrum, and in an incision going through the placenta with patient confirmed placenta previa are at risk for blood transfusion, injury to nerve organs, cesarean hysteromic about 0.2%, extensive care admission and death. There are also an increased risk for subsequent pregnancy. The prognosis of placenta previa